Most importantly with her, I'd say for the differential diagnosis you mentioned is that for her, I mean, it just screams diverticular until proven otherwise. We have an older patient, painless, bright red blood per rectum. She's had a good drop in her hemoglobin. Seems like it could have been quite voluminous, the amount of blood that she's been losing. So, that just screams to me that's a clinical situation, or the illness script, as some I've heard it referred to as, of a diverticular bleed. So fast on, lots of blood, and then may stop. Certainly could be from like an AVM, but when I'm talking to her, or maybe before I start my scope eventually, I'm thinking this is going to be a diverticular bleed.
Welcome to Critical Care Time, the podcast for everyone who cares for the critically ill. I'm Dr. Nick Mark, joined as always by my trusty sidekick, co-host, partner in crime, Dr. Cyrus Askin.
Nick, it's great to be here. Thanks for the introduction. I was a little worried I wasn't going to be here owing to the fact that we had to drive to El Paso from San Antonio unexpectedly due to our generational dust storms that we are in the midst of here in the Sun City. And it's been just a boatload of fun. So.
Yeah, that sounds charming. I was totally picturing something out of Dune when you guys were talking about this. So yeah, that's the joys of living in the Great Desert.
Yeah, it's definitely reminiscent of Dune. I'm just waiting for the great Shai Hulud to emerge and eat us all. And who knows? I mean, things might actually turn out better for us than they're going now. I don't know.
I mean, in some ways, this is the perfect episode to talk about if you eat the wrong thing, right? If you're like a worm and you need to call an expert, right?
Yeah, I love that. So maybe we shouldn't bury the lead any longer. Nick, what is it that you're actually getting at here?
All right. So as our listeners know, we talk about shock a lot on Critical Care Time. Our very first episodes, we talked about shock. We've talked about many different types of shock, obstructive shock. We've had some PE episodes and tension pneumo episodes. We've talked about cardiogenic shock a lot recently. Well, today we're going to talk about a different kind of shock. We're going to talk about hemorrhagic shock by discussing GI bleeds.
Many of us who work in medical ICUs will primarily encounter hemorrhagic shock in the setting of a GI bleed, i.e. kind of the life-threatening GI bleed that might get all our sphincters to tighten, no pun intended. Of course, we will note here that GI bleeds do come in many flavors. We're going to talk about that a little bit today. And admittedly, it would be a pretty heavy lift for Nick and I to handle on our own. And I think we'd be doing a disservice to our audience. So, in the spirit of that, we have recruited the expert help, an expert consultation, if you will, with a dear friend of mine, an illustrious gastroenterologist who will be joining us today. Can't wait to introduce him in just a little bit.
Yeah, we got some great stuff here. This is going to be part 1 of 2 at least, because we're gonna sort of separate this episode and talk about non-variceal GI bleeds, as we'll talk about why later, and then variceal bleeds and cirrhosis will be in a subsequent episodes. I still think we're going to have tons of great stuff: pathophysiology, risk factors, risk stratification, how to get gastroenterologists out of bed at night. There's actually a phrase that you can utter that kind of unlocks their programming and gets them into the hospital. So lots of good stuff here. Stay tuned.
Let's get to it. All right, folks, like I said earlier, we've got a guest teaming up with us today to explore the wide world of non-variceal GI bleeds, who's an expert in the field and one of my closest friends from residency back when I was in San Antonio. Our guest today is Dr. David T. Dulaney, who's a gastroenterologist in San Antonio. He's also the program director for one of the GI fellowships in the country's 7th largest city, as well as an assistant professor with USU and an adjunct assistant professor at UT Health Science Center in San Antonio. His interests in the field of gastroenterology include IBD, or inflammatory bowel disease for the uninitiated, eosinophilic esophagitis, endoscopy, and clinical education. So perfect guest for us today. He's an active member of the ACG with multiple committee memberships, as well as committee memberships within the World Gastroenterology Organization. He has been selected for multiple courses on clinical education, including the Train the Trainers workshop with the WGO in Calcutta and the Stanford Faculty Development course with USU. He's the co-author of over a dozen articles and presentations on inflammatory bowel disease. Outside of GI, he lives in San Antonio with his wonderful wife, a brilliant internist, and I can attest to this because she is wonderful, as well as his beloved beagle mix. Shout out to Archie.
Those are 2 separate. Those are separate. We want to be very clear.
Yes, they are separate. Yes, yes, they are separate. This would be a very odd episode if that were not the case. His interests include cooking with various levels of success, all things automotive and being a Formula One fan. And this is important before Drive to Survive started. Unlike myself, who I didn't become a fan until I met David slash Drive to Survive started. So without further ado, David, welcome to Critical Care Time. So happy to have you with us today.
Oh, thanks for having me on, guys. I'm still waiting for when the actual expert comes on to talk about GI bleeds. I'm just some guy. But no, I'm really excited to talk about this and then give, that insight into the GI perspective and how the secret code words that we're all taught, and it's actually tattooed on the unmentionable areas of our body to get us up at night. So hopefully we can educate everybody on that.
Nice.
I
Can't
love
wait
that.
to divulge that.
Yeah.
Anyway, David, welcome to the show. Great to have you here, man.
Yeah, thanks.
Maybe we could start off by telling us, what your superhero origin story is. Like, what got you into GI?
Oh man, I guess we have to take it all the way back to third year of med school.
Oh God, I thought you were going to say in utero.
No. But started out, my first rotation was medicine, and we had a lot of cirrhotic patients, and I was like, man, these like a lot of really cool stuff to talk about around a really cool pathophysiology. And then my next which was awesome. Then my next rotation was transplant surgery. So I was like, oh, this is great. I'm gonna work with cirrhotics all the time, become a transplant surgeon. So I kept doing surgery electives and stuff, and then
And then you worked with transplant surgeons, and you realized you didn't want to work with them all the time. So.
yes. So it came to a point where I was doing all these electives in a row that were surgery. So I was still getting up at I'm sure anyone who's a med student listening to this can attest, or those who have recently finished med school, they get up at 4 a.m. to go in and round on everybody and whatnot. And then I switched one for a GI elective, and it was so awesome because I got to see all manner of things. Let's see, got to hold the EGD scope and help take someone who was continually, I guess, it's part of their disease was swallowing things like pen caps and all those kind of things. So I got to use we call it a Roth net. It's a net that goes through the scope to help pick one of those up in the stomach. Got to see ERCPs and EUSs and bleeding cases. And the best part is that those cases were really short. I only had to be standing for 30 minutes. So I was like, wow, this is far better than standing for 12 hours on end for a transplant surgery. And then what's kept me in and kept me going, you notice I mentioned the liver a lot, but then it didn't come up in my areas of interest now. I still love it on the inpatient side, all those big bleeds and those crazy physiology, but it's kind of boring clinical practice. So I fell into inflammatory bowel disease, where I felt like I really got a chance to change people's lives and make them better through all these crazy new medications that are coming out. And of course, I still love doing even just routine outpatient colonoscopies. I've had patients who come in for a myriad of complaints. Actually, one just recently, and he was here for he's a young guy, very very simple complaint, but took out a 25 millimeter tubular adenoma. And if he had to wait till this 45-year-old screening time, we'd definitely be having a very different conversation than now when I say, hey, it's out. We'll see you in 3 years. So it's those little boosts that keep me going. And then of course, what we're going to talk about today, the big old bleeds that really get your heart rate up and get you excited, when they come in. So I guess that's
nice.
Yeah. And not just your heart rate, but the heart rate of the patient too, if they're having an appropriate physiologic response.
Hopefully, yes. Hopefully, yeah.
So, David, now that formalities are in the rear view and, we've gotten to know you a little bit, I think we can probably shift our focus onto the topic at hand, which would be those non-variceal GI bleeds. So we mentioned this a few times. In fact, I just mentioned it a second ago. We decided really at your recommendation to split this content up into non-variceal and variceal GI bleeds. What was the reasoning behind that? Maybe you could shed some light onto that.
Oh, yeah, totally. Well, I guess the easiest thing is that it was one less set of guidelines for me to look at for this, but I'm just kidding with that. Is that while there's still blood for some reason or another in the GI tract, they're very different pathophysiologies. So when I was talking about my origin story, I was talking about liver patients, and we think of variceal hemorrhage most commonly in them. That's generally from a venous source that has a significantly higher capacitance than its baseline, because the esophageal varices are collaterals from that increased portal hypertension. In addition, you have other hemodynamic issues or angiogenic issues that cause the varices to just act very differently than the normal bleeds we'll be talking about today. I say normal. At least, eventually also their hyperdynamic circulation, their difference in hemodynamics from the portal hypertension and just their cirrhosis in general makes the variceal hemorrhages really different than what we're going to talk about today. Generally, if someone's going to the ICU with what we're going to talk about today, it's like from an arterial source. It's an ulcer, it's a diverticular bleed, it's something like that. But generally, prior to the bleed, the patient has relatively normal hemodynamics and will compensate in kind of a more predictable way. There's obviously risk factors we'll talk about that can put them at risk for serious complications or like a harder to control bleed, like anticoagulation, antiplatelet therapy, something like that. But generally, at baseline, they won't have a lot of those significant complications that we'll see from the variceal and the cirrhotic, variceal bleeds in the cirrhotic patients. And of course, like from my standpoint, the guidelines, as I mentioned, totally separate. The urgency of what's recommended for me to go in and do my index scope, either a diagnostic or therapeutic, is different. The patients, for many reasons, are different. A lot of these initial treatment then what you add to a variceal hemorrhage is different. So like what I ask my ICU, my IM, the ED colleagues are a little different. And then what I do once I'm in there with my endoscope and all the different gadgets and tools and everything can be different as well. So, that's why I figured let's start today with the more normal patient, as it were, who's exsanguinating in front of you and it's pouring out of either their mouth or their anus. With the upper GI bleeds, lower GI bleeds. And then next time, let's make it crazy. We'll talk about all the hemodynamics and the portal hypertensive bleeding. And plus, like, no one would want to hear me jump on this podcast and talk for like 4 hours as like this GI interloper who's ruining critical care time by just sitting here, before I go to bed and nothing can wake me up before the morning, right? We all do.
Well, I think that was a pretty very well thought out answer, David. And I think gives me at least a pretty good understanding for how the bleeding can seem to come from the same kind of source, i.e. like esophageal or upper GI bleeding. But the reality is in one subset of patients versus another set of patients, it's actually very, very different in terms of the way we need to approach it as intensivists, the way you would approach it as a endoscopist, as a gastroenterologist. So that's, I think, very helpful for me. Maybe we'll take one other step back, because my initial thought was, let's just split it into upper GI and lower GI bleeds.
Which I think is what most people are taught, right?
Yeah, definitely. Oh yeah, especially, and that may be what you have presented to you, is that melena hematemesis versus hematochezia, and that's like the chief complaints that will come up to you guys. So there's some things that, like, especially maybe next time we'll talk about more of when you can bump up varices on your differential diagnosis versus saying like, that's probably not what's going on. Let's treat it just kind of as your run-of-the-mill massive upper GI bleed.
Yeah, just run of the mill life.
Run of the mill.
So maybe we can talk then briefly, reach back to that traditional dichotomy and talk what constitutes an upper GI bleed versus a lower GI bleed.
For sure, yeah. So I mean, upper GI bleed, by strict definitions, it's anything that's proximal to the ligament of Treitz. So that's something bleeding the esophagus, stomach, or duodenum. Of course, like, yes, variceal hemorrhage is within that realm of an upper GI bleed. But as we've already kind of mentioned, we'll talk about all the intricacies and nuances of that later. And then keeping with tradition, lower GI bleeding is anything distal to the ligament of Treitz. So I'm talking basically jejunum and on. That being said, now with changes in small bowel imaging, with both radiographic studies, so I'm talking about CT angiographies, VCE, that's video capsule endoscopy or enteroscopy, as well as other endoscopy techniques, things like balloon assisted endoscopy, the diagnosis management of that like small bowel area has changed a lot. So now, by our guidelines and even the workup and whatnot, has made that completely, a separate topic entirely at this point. Then we'll talk about, I guess, the differential diagnoses, but then again, those can be different for those kind of obscure GI bleeds that aren't found on a normal diagnostic EGD or colonoscopy. So for this point, as the ACG, so it's the American College of Gastroenterology, I'll say ACG a lot, so I just want to, bring that to everybody's attention right now before I start using a bunch of society names. Lower GI bleeding primarily focuses on hematochezia, that'll come from sources in the colon or the rectum, or colon and rectum or something like that. I've seen a few, I mentioned the small bowel bleeds. I've seen a few really hemodynamically significant ones in the time, but the ones that are from the upper GI tract or the lower GI, so like the colon, are far more common. So, and even for those significant small bowel bleeds that I've seen, the critical care principles are really the same in terms of the resuscitation and whatnot. So we'll just focus on the two big ones that you'll most commonly see, and just stick with common things being common for this one.
Excellent. Okay, I think that's a great kind of level set. When we were in med school, we were taught by anatomists with this upper and lower dichotomy, but I think it's really great to clarify that it's really more of a functional way that you separate them, right?
Yes,
that's why often when calling GI on the phone, the first question is, do they have known varices, right? Because we're trying to put them into one of these two pathways. So very helpful. Now that we've defined some of these terms, maybe we should talk about why this topic, non-variceal GI bleeds, is so important in the intensive care unit. What is it about these patients that is so important for us to understand as intensivists?
Oh, for sure. I mean, one thing that's so important to know is that it's so common, GI bleeding writ large, not necessarily just ICU ones, is one of the more common diagnoses for hospitalization. Recent estimates from I saw ACG and AGA, the American Gastroenterological Society or Association, say about 500,000 patients annually are admitted with this. And of course, you've all seen this, and they can get really, really sick and have really, really bad things happen really, really quickly in them because how much blood they're losing. And then, getting everyone on the same page with this. I think, I've always said this to my trainees, is that healthcare is a team sport. So I can't just treat these in a silo, waltz on in with my scope and say, okay, here we go. So I rely heavily on my emergency medicine, hospital medicine, critical care medicine colleagues, as well as diagnostic rads, interventional rads. And that's not even to there's RT, there's ICU nurses, there's transfusion folks, all those kind of things. So hopefully what I'm hoping today that we can do is I can bring in at least a GI perspective of here's how I think about them. Here's what I would recommend before the scope, what I am thinking when I'm going into a scope for these folks. And so, bring that, my thoughts, and combine it with all the expertise you guys have as being the experts on shock management, resuscitation, transfusions, et cetera, et cetera. So that's what I think. There's a significant overlap in these just based on their commonality. And, it's where we all have to work together as a team to do what's right for the patient, who can be in pretty extreme, extremeness right in front of us,
Yeah, and I think, Nick and I often refer to critical care as being a team sport. And one of the major kind of principles of this podcast, or I should say, one of the major missions of this podcast, is to be a big tent podcast and kind of incorporate all those team players. And I appreciate what you're saying, that paradigm can be applied sort of one step back at medicine at large. And so I think it is important, for this episode to be an opportunity for folks to hear about all the different roles that are required for a patient to have a good, successful outcome who's coming in with a GI bleed like this.
Definitely.
And it's very helpful, by the way, for that team, coordination, to understand how your colleagues think, right? Because
definitely,
we have different training, we think about different things. So yeah, very, very good to give us kind of your perspective on some of these problems that, even though they're common, we see every day, we don't view through the same lens necessarily.
Exactly. When you're talking to someone who I've been described as the ortho of internal medicine, we'll have a little different perspective than the rest of us.
Ortho, yeah. Yes, man. I wish I had become an ortho in internal medicine, man.
Yeah, who doesn't?
Sometimes sputum, sometimes you just get sick of sputum.
I can't, that's the one, I can't do sputum. There's plenty of other things that have happened, and I've experienced as a gastroenterologist. You can assume we don't need to do a full list of them, but sputum is that got me out of thinking about ENT,
Yeah.
Have you guys ever seen that algorithm, which is if you hate kids, you're an internist. If you hate adults, you're a pediatrician. It's kind of which body fluid do you hate? If poop is too much for you, consider cards or palm.
Right.
If spit is too much for you, consider GI.
So yeah, no, all kidding aside, I love my job. I think everyone on this podcast probably does, which is important.
Yes.
So with that all being said, I think we should probably talk a little bit, as we often do on this show, about pathophysiology as it relates to the non-variceal GI bleed. In prior episodes, we've talked about hemodynamic profiles and general principles that relate to, how we might manage hemorrhagic shock in broad strokes. I'm wondering maybe, with that background, if David, you might be able to unpack for us some of the etiologies of non-variceal GI bleeds and how they evolve in the hopes that it might inform our approach to resuscitation, if there is any change in the way we might approach
Yeah.
these patients.
I mean, in terms of the etiologies of GI bleeds, so I'll talk about upper ones first. Of course, like massive differential diagnosis. Every medical student intern has seen the largest, this massive list of things that can cause upper GI bleeding. In terms of the ones that I think will bring someone to the ICU, generally to be from, as I said, more of like an arterial source. So high stage. By high stage, I mean forced 1A. 1B, maybe 2A as well. Peptic ulcer disease, a Dulafoy lesion, which can be extremely frustrating because those tend to bleed a lot and then kind of disappear under the mucosa. Obviously, you can imagine an aortoenteric fistula being kind of a massive bleed. And then from the lower side, like diverticular bleeds as well. In terms of upper GI bleeds, you mentioned how kind of they present. We always think classically of melenic stools. Just to kind of get this out there, the proper term, and for anyone listening this, is melenic. You can't have a melanotic stool because I don't think poop has melanosis associated with it.
I'm going to say that's melanocytes in the poop.
Melanosis, yeah. The melanin is quite low in the stool.
I guess it depends what you ate, but
yes, right, yeah. Depending on whatever you ate, there's our like version of Mixapp or the others, board prep thing. There's actually a question where there's a little like sentence about like your colleague calls you on a patient with melanotic stools and you don't correct him to tell him it's melana. But anyway,
that's awesome.
Yeah,
I wish we had more pedantic questions like that in RQ.
Oh yes, very pedantic. Very like the snark was high in that one. I can't believe it got accepted. But when you're at a book with like, several hundred questions, I guess that gets through.
You got to throw that in.
But so melanic stools, and like with or without hematemesis. So hematemesis, when I'm hearing that from the ICU team, I'm like thinking, okay, it's either a source in the stomach or maybe really largely just distal to the pylorus. So the blood is refluxing through the pylorus into the stomach and it's becoming so voluminous that the only way for it to go is up and out of the patient. Of course, we think about massive upper GI bleeds. They can also present with bright red blood per rectum because blood is a fantastic cathartic through the GI tract. And those are ones that you may see in the critical care setting as well. But they may very well, at that point, if you're having bright red blood per rectum from an upper source, you're thinking hematemesis, definitely melenic stool during the pre-endoscopic course. Lower GI bleeds, it's hematochezia, painless or otherwise, something to kind of differentiate. Generally, if it's painless, we're thinking more of that diverticular bleed. Those are also ones that may start really quickly. There's a lot of blood, and as we've probably all had the patient where, by the time they're stabilized and they're prepped, we go in and the blood's all gone. Otherwise, there may be slow bleeds in the proximal colon that can cause kind of a maroonish, maybe honestly verging on a melenic type of stool, but those are really unlikely to ever get to the ICU for admission just because of their slower rate of bleeding and less likely to be from like a arterial source that's going to cause hemodynamic compromise.
Got it. So lots of things on the differential, but a shorter list when we're talking about people where the bleed brings them to the ICU. Usually we're thinking arterial sources. When you're hearing a history on these folks, what are some risk factors that kind of, perk you up?
Oh, totally. Yeah. I mean, things that I'll ask everybody, common things being common. Obviously, we think about NSAIDs, the regional, this sounds odd, but things that I've learned since practicing is to learn whatever the regional home remedy is that contains a boatload of aspirin. So, I don't know where Goody powder is from, but I never heard about it, in the North, but that has like, one dose of that is like a gram of aspirin or something like that. It's insane. So those are always going to be the greatest, ulcers, particularly duodenal ulcers you'll ever see. Of course, I think about H. pylori infection. So that's something that's very common in the region where I live. There is kind of a regionality to it, and also it tends to cluster in families. There's certain ethnic groups that may be more likely to have it. Of course, age as well, if there's someone who's prone to AVMs or angioectasias. And then, of course, with age also comes diverticulosis in the colon and other reasons for which they may be on anticoagulation, antiplatelet medications, those things as well. So those are the things that maybe also not say like, okay, here's my differential diagnosis maybe causing this, but also say, ooh, hey, this may get really bad really quickly, and this one is one, we really need to keep an eye on. And maybe if they look okay in the ER, maybe I'll talk to my critical care colleagues and be like, hey, can you go take a look at Mr. Smith or Mrs. Jones? They're doing all right now, but with the medications they're on, they were, taking goody powder like nobody's business, and I'm worried that this may get pretty bad pretty quickly.
I think that's like, I think that last point that you make is a really important one. And I've been guilty of this myself. I don't know if Nick, if you've done this, probably not, because you're a lot smarter than I am. But there have definitely been cases where, you hear a story and you're like, this isn't like the just in case unit. Like, I don't, this is
Yeah.
not someone who sounds all that sick. But we sort of, I think, might miss the forest for the trees there, and sort of like focus on what we're seeing right now, and not the big picture, which is like, yeah, okay, they're not like actively exsanguinating right now, but they have risk factors A, B, and C, all of which make them high risk for doing
Right.
this at 1 a.m. when the hospital's minimally staffed, and there's just like, a July or August intern alone responsible for this person. So I think that's a great point about like just anticipatory disposition. I don't know, Nick, what your thoughts are on
Yeah,
that.
no, I completely agree. I've been fooled in the past too. I mean, I always think about that Wayne Gretzky quote: Don't go where the puck is, go where the puck is going." And somebody who's okay now but getting worse is somebody that I'm very
But I
worried
think that was
about.
Michael
Especially,
Scott, actually.
Michael
Oh, yeah,
Scott
that's
had a
right.
different one, but yes,
It
yeah.
was Michael Scott, Wayne
Quoting
Gretzky.
Wayne
Yes,
Gretzky.
yes, yes. Hey, at least he didn't plagiarize him, right? He
There we go.
acknowledged the source.
Cite
He
your sources.
referenced.
Yeah. No, I mean, I think it's important, especially if you have that sort of sense that like, okay, this person's therapeutically anticoagulated. They've got, serious risk factors. They're okay now, but where are they going to be soon? I think that's a really important consideration. It's never a bad idea to just lay eyes on somebody and see how they look, because sometimes the vital signs, like a heart rate of 105 can mean a lot of different things depending on the person.
Yeah, especially if like, we're talking about other risk factors. I mean, I mentioned anticoagulation, antiplatelets, maybe other cardiac issues. They're on a beta blocker. So that 105 is actually them like,
Now it's a 65 and they look great.
yes, yeah, right, exactly. So other than risk factor, I think about for like a really complicated course and one that maybe I would not be involved in, just to, if someone, ER folks or ICU folks are listening, obviously, this may come up a little bit later as well. Any vascular interventions, so AAA repair, recent or otherwise, I think about, was this very rapid, very voluminous bleed? Was that their Herald bleed and they actually have an aortoenteric fistula, which I've seen one of those and one aortoesophageal fistula, both absolutely terrifying things, and very glad that I didn't just blindly stick a scope down in there. And, my colleagues got the CT angiography and they were able to get actually treated well. So, but something just to consider as well, if maybe we have some ER colleagues down there, something maybe to add to their history of just like, hey, do I need to get a CT before I call the ICU, medicine, or, the gastroenterologist themselves?
That's a great point.
Those are great points too. And sometimes too, like I know we had a case like this in the past where someone had like pretty significant gut ischemia and subsequent bleeding in the setting of a vascular intervention,
Yeah. Oh yeah.
where the sort of like the therapy kind of caused the problem. So I think like that's a really great point that you're making, is being deliberate about your history taking, very intentional, etc. Okay, so with that great kind of discussion, I think we can probably move on to specifics here. And what I want to focus on would be labs. David, you talked about some particular imaging approaches that I want to touch on, because I know the teaching that I've always received is that CTs are very bad for endoluminal bleeding, but I think that's just your like general CT with or without contrast. I think you're getting at something else. And so anyway, I was hoping we could talk about labs, imaging, and maybe some of the clinical decision support tools, things like the AIM-65 or the Oakland score that I've come across. And so, what are you using in terms of labs? What are you looking at in terms of imaging? And then finally, what kind of scoring systems should we actually keep in our toolbox, and which ones are better kept in the dumpsters?
Okay, perfect. Yeah. So like for labs, I mean, I would treat it just like any other person that's coming in with bleeding. Of course, knowing the patient's history and their, medical history and what meds they're on. So obviously, we're always getting CBCs, we're getting our chems, we're, INR. I think I'm going to table the discussion of thromboelastography or those kind of functional assays because it's actually going to be much more exciting to talk about it and much more interesting during the variceal hemorrhage just because of all the wonkiness that happens with a malfunctioning liver. So generally, I would say just, most of the labs that I would get are the ones that you guys always do get, at least in my experience. You know, if lactate or other things like that, or blood gas drives your guys' management, that's great. Again, ortho of medicine, I don't think about that. But and then imaging findings, I'd say we'll talk. Maybe when we talk about lower ones specifically, we'll go into more of like when to get a CT angiography. If I'm assuming it's an upper one, generally I'm not getting not pushing really hard for CT to start, just because there is the ease of using using my gastroscope, being able to see and locate the bleed, versus obviously the lower. More often than not, we're starting with a bowel prep or something like that. That may kind of, not that it's intentional per se, but it does delay us getting camera in there and getting interventions going on. But the support tools, the clinical decision tools, I'm really glad you asked about those. So full disclosure, one of my majors in college was math, so I'm a huge, math and stats nerd still, even though I've lost most of my mojo on it. So don't ask me to do anything
This is
like
a lie. That is a bold
that's
faced lie.
arithmetic,
I've
Cyrus. So
seen.
calculating the tip is an arithmetic.
Oh, I've seen it, man.
So like, and this is something I really want to like talk about for all the trainees and students and everyone else who's listening. So, whenever you're doing a clinical decision tool, make sure you're listening to really what it's telling you at the end. So the one that we used most often that's recommended by the ACG, our European colleagues, the ESGE, and actually the ACP also had a multi guideline recommending the Glasgow-Blatchford score. You mentioned the AIM-65. It's actually funny. I couldn't see much on those for it, but I did see the ACP guideline. I think 2021 was against it to see who was at low risk for rebleeding and mortality and wouldn't require admission. So, okay, taking a step back. So we already mentioned the Glasgow-Blatchford score, but let's say we wanted to make like the perfect score to know who am I going to like admit, who am I going to call GI or call medicine or whomever for admission, and who can I send home? So what do we really want with that? We want something that has a really great sensitivity because I would love to admit anybody. Yeah, sure, I may get some like people who in the end didn't need to get admitted, but I'd rather admit more and be safe than be super
You'd rather
specific.
false positives.
Yes, lots of
than
false positives, but a
negatives.
false negative, I mean, you are that that's scary if you're discharging someone who really needed admission. You want to get those down to zero at all costs. So, based on all the studies that have been done thus far, the ESGE and the ACG, they're one of the best sensitivity over all of them. And the ESGE guidelines, which we can link in the show notes, along with the ACG ones as well, gives a good analysis of the sensitivity and specificity between GBS, AIM-65, Oakland score, and GBS came out on top there. So getting a 0 or 1, saying that, yeah, you can probably go home, we'll do this kind of as an outpatient, has a 99%, roughly 99% sensitivity, with like on the confidence interval being like 97 or 98%. So that's really what we're trying to aim for every time we're using one of these clinical decision tools, to try to find the best one to get our best answer that's safest for our patient. So long answer to a really like simple question, I suppose, but I only use the GBS, and that's the one that's been like most commonly recommended across multi-society guidelines there. That being said, these and they kind of hammer this home more. The ACG says it's verbatim with the lower GI bleed guidelines is, you know, always look at your patient in front of you. Like we're always, numbers are great. These clinical decision tools are great, but that's not the end all be all. So make sure you're really assessing your patient, seeing what their maybe ability to come in later for an outpatient workup for this bleeding or anything like that is. If it's something where really, yeah, they may not be rushing to the ICU and you guys may not be taking care of them. But I'm saying this to all the medical students, emergency medicine folks, and internists who are listening. If it's the and well, if there is a GI, hello to the one,
Mhm.
um, you know, if it's in the best interest of the patient to admit the patient, even if your decision tool is telling you not, do it. You're never in the wrong for, again, increasing your sensitivity, even if it means lowering your specificity.
I think that's a great overview of kind of how these tests are properly used in this population. Cyrus, I know you mentioned the AIM 65. Do you have any thoughts on that one, David?
I don't really use it, frankly. Honestly, I was actually surprised to see it mentioned verbatim in the ACP guideline recommending against it. Really, the GBS is kind of the way I go. Again, that's for upper GI bleeds. There are other scoring systems you can use, like Rockall and the pre-endoscopic ones. It really doesn't drive my and Oakland scoring. It ones with pre-endoscopic scoring systems don't really drive my decision making as much as GBS. That's the one I kind of lean on because that's just been the one that's consistently performed the best amongst all of them.
Gotcha. So bookmark Glasgow Blatchford, delete AIM 65,
Yes,
and probably ignore the other ones too, unless you really want to nerd out.
Invest in GBS to the moon, guys.
To the moon, just like GameStop.
And Glasgow, they've already got the coma scale. They got another one now. Come on,
those Glaswegians, man, they're crushing it.
Glaswegians. Yeah, no, I think that's super helpful because I think like when you look on, not that they're a sponsor or an affiliate, but a lot of folks use MD Calc. If you look at MD Calc and you look through all the different scoring tools, there are a number of them, and so it's nice to know, hey, this is the one that's really guideline directed. This is the one that our colleagues might want to hear about. I also think it's similarly important, actually. That said, I think what's even more important that you mentioned, David, is the fact that like these are clinical decision support tools. You are still sort of the arbiter of that patient's disposition. You're the one with the eyes looking at the patient, assessing the patient. Those scoring systems don't take into account, likelihood that this patient is going to be lost to follow-up. They don't take into account every medical comorbidity under the sun. And so I think your point is very well taken in that you really have to like use those tools, but ultimately it's going to be your own clinical gestalt and your own assessment of the patient that should drive the disposition decision.
Oh, definitely. Yep. Totally agreed.
Yeah, I don't want to go down a Bayes theorem rabbit hole too much here, but like if pretest they're super sick, there's really no scoring system which is going to make them not super sick after you score them,
Right.
Right. So, I mean, yeah, you got to put it contextually.
And that's what my like gripe sometimes with the like pre-endoscopic Rockall is like, are they old? Are they sick? Yeah, well, they'll probably be sick. Like, okay. And then, I mean, ditto with the GBS, I suppose. You're adding in some of those characteristics as well, and just kind of this is how it is.
Yep. Okay, well, I think we've given our listeners a great foundation for sort of talking about, what are the historical things that I care about? What are the risk factors? How can I risk stratify a little bit? Let's put our newfound knowledge to the test and do some cases. So let's say you got a 64-year-old man with a history of hypertension, osteoarthritis, chronic alcohol use, who presents to the ED with complaints of melena for the past 2 days and an episode of hematemesis earlier today. He reports intermittent epigastric pain for the last several months, which worsens after meals but improves after he takes antacids, which I guess he's been doing a lot of. He's been taking ibuprofen daily for knee pain, maybe some goody powder to get a regional. But he's a little wishy-washy about how much he's been taking. On arrival, his vitals are blood pressure 98/60, heart rate 110, respirations 18, satting 98% on ambient air. His physical exam reveals mild epigastric tenderness, no peritoneal signs. His labs show a hemoglobin of 8, down from a baseline of 13, and a BUN of 47 with a creatinine of 1.1. Coags are normal. So what jumps out to you about this, and what are you thinking right off the bat?
I mean, I'm thinking I can smell the melena from here already. It's kind of one of those ones where as you walk into wherever you are in the ER or whatever, or I get into his ICU room, it's like I'm expecting to get that kind of characteristic smell that I'm sure you two know as well as I do. And for those who haven't smelled it,
it's plot twist. This is actually a milk alkali question.
You're right.
Sorry,
sorry, Doug. Yeah.
Gotcha.
There's a second part here where
yeah, part 2.
It's all the antacids.
Yes, right. Well, they didn't tell you in the question.
Just care about all the antacids.
Thank you. I'm glad I'm here for that.
Yeah. All right, we're going to get you off and get the nephrologist to finish this episode.
We have this joker off here.
Yeah. I couldn't help myself. Okay, sorry.
That's hilarious. I love that. Okay, so what sticks out in the history? Obviously, I'm thinking, his history of osteoarthritis, the fact he's been taking the ibuprofen daily, the different kinds of pain. Maybe it's more of like a dyspeptic kind of pain, but it seems like we're pointing ourselves in like a PUD kind of realm. In terms of, how he looks right now, yeah, the blood pressure, the heart rate are all giving me a little bit of kind of worries there, and of course his drop in hemoglobin and then the elevated BUN based on what his baseline may be. That is likely significantly elevated, huge BUN to creatinine ratio there. So
David, before we keep going, you mentioned that BUN to creatinine ratio. Can you just maybe underline why we care about the BUN in these patients? I mean, I always thought that was just like, at least, I mean, I know better
Isn't that
now.
a nephrology thing?
Right, exactly.
Well, it's so we can pretend to be nephrologists. Actually, again, like it's misinterpreting data is the point of the ortho of medicine. No, so the BUN will increase in someone who's having an active GI bleed. That's the digestion of various proteins and whatnot from the blood as it's being absorbed in the duodenum. So for learners that are listening along, the ratio where I can say like, okay, this is probably more GI bleed rather than as we always used to think about like the pre-renal azotemia is about 30-1. Definitely going above like other studies that in the mid 30s or even higher. I'd say you get the best sensitivity of the at least 30-1 ratio going on there. So that's where I will look when we first get that first call, or maybe it's I'm seeing them in the morning and they came in overnight or something like that, is that I'm checking their BUN trends to see. And we'll talk about that later after maybe we get this case to its resolution of what I'm looking for out of the BUN in the future.
And just as a fun animal fact aside, because I know our listeners love when I go on these weird tangents, if you look at most bats have a BUN creatinine ratio, which is about the same as ours, because most bats eat either insects or fruit or nectar. But there's a subgroup of bats that eat blood, vampire bats, and their BUN to creatinine ratio is about 45-1. So they follow this rule, right? That high protein load, and they actually have all these cool adaptations to do that. So
what
remember,
about the Cullens from Twilight?
I'm not sure that's been studied adequately. Future study required.
Yes, right.
I'm on it. Oh my gosh. Okay.
As someone who subsists on insects and fruit and whatnot, yeah, I mean I could see that.
Yeah, nectar.
Nectar as well, yes.
Let me got to have a balanced diet with nectar.
Well, of course. I mean, I have something to balance out all the protein from the insects.
The insects.
Right? Yes.
Okay. Well, thank you. Thanks for clarifying that. I just wanted to make sure that folks kind of realize it's not just that like they're presenting with a GI bleed and what looks like a pre-renal azotemia. It's actually quite a bit different than that.
Yes. Yeah, definitely. Now they can still, be volume down and everything. So like in terms of next immediate steps that I would recommend for this person, obviously, you guys have already discussed this, I'm sure. It's like just standard measurements for that it would take for really anyone with upper GI bleed. So potentially getting this person to the ICU, or at least having the ICU evaluate, large IVs, fluid resuscitation. With someone like him, given that he's had, there's been a transition from melenic stools to now hematemesis, maybe there's something that this GI bleed is getting worse, or if there is a peptic ulcer in there that has been upstaged, something that's actively bleeding. And if I'm going to go in, I may see a lot of blood, a lot of clot hanging out in the stomach. So I will more often than not kindly request endotracheal intubation as well, just to protect the airway while I'm doing my my procedure, in case as I'm insufflating the stomach with the usual carbon dioxide that we use, or air in some other center, just room air in other centers, that if there is blood expelled, that the airway is at least protected.
I would much rather get asked kindly to intubate somebody before the procedure than asked hardly to intubate somebody during the procedure.
Yeah, I've never liked the, hey, can you come back in here? Yeah, no, luckily that's never happened to me, but I could imagine that's horrible as the intensivist. Let's see, other things, I guess, we kind of already discussed a little bit of the history, but, I want to go back to some of the labs, actually. We mentioned hemoglobin. Other things as I'm formulating my differential diagnosis, we did mention his alcohol intake. chronic alcohol use, something to consider, of course. If I'm thinking, and again, this will come up way more next time, so stay tuned, everybody. If I'm thinking about like clinically significant portal hypertension, and I have a second to look at his baseline labs, or maybe if he had some baseline labs before as an outpatient, I'll check on the platelets. If they're above 150, I can pretty clearly usually rule out clinically significant chronic portal hypertension that would put him at risk for varices. So if it's above 150, I'll say, okay, like I'm not really concerned about varices right now. My techs always bring the bander kit, but I'm not saying, hey, let's prepare to band or anything like that. Or if I'm talking to the ICU, I'm not saying, I'm not empirically asking for other elements of volume resuscitation or resuscitation in general, like octreotide or anything like that.
Great.
Yeah. Otherwise, obviously in terms of, we already discussed a little bit of risk stratification in the past. If you go down the GBS, he's a pretty high risk kind of patient. So then here comes always the worst part of consulting GI, and I am aware of this, I know, is that when are you going to do your scope? Like, when are you coming in? I called you. This poor gentleman. Yes, he's a gentleman. Potentially. Maybe he's not. I don't know. But
I'm not sure if he's landed gentry or not. Yeah,
that's right. Yeah,
he might
we're
just
not
be a
entirely
dude.
sure. Okay, yeah, so this yeoman here. We're not really sure. He's bleeding. Why aren't you coming in and fix it? And I get that. So the way we define endoscopy is like, and by the studies, is urgent or early. Urgent is with before 12 hours of presentation, and then it'll get extended by the studies to early, so within 24 hours. In terms of coming in for an urgent endoscopy, studies, direct studies, meta-analyses, combination, systematic reviews, etc., have not found any improvement in outcomes with urgent, so within less than 12 hours, versus early. In fact, there are some studies showing that there's actually a worsening outcome. So, increase in mortality if you go in a little too early before a full resuscitation. That being said,
Yeah,
I mean,
I was
that's
going
all
to say, I
from,
wonder if that's a resuscitation issue.
it is. It's 100% a resuscitation issue. Yeah. Know your team, know the capabilities of your center, and obviously, if you're the GI, the one who's listening, do what's right for your patient. So we know all this pooled data, but this is in my experience. This is not from a guideline or a study or anything like that. There have been times that someone has been very sick, and I've gone in much sooner than 24 hours. Sometimes it's within a few hours or as fast as my team can get there, because this may be as good as they're going to get, or I need to have a diagnosis of the location of their upper GI bleed to assist eventually in transarterial embolization with IR, or at least to stop some kind of significant bleeding so they could get to the IR suite eventually. So, again, that's just my experience. If someone is at a point where I think that it's safe for me to go, and I mean, I'm always surrounded at the center where I work at. I'm blessed to be surrounded by a really great team, lots of people, lots of very highly skilled, highly trained people. Once I'm confident that I can do my job and the patient will be safe while I'm doing it, because I know I have a great team around me, I will certainly go in faster than, the 12 or 24 hours, something like that. By the guidelines, sometimes you may get these quoted to you, is that 24 hours is what's within 24 hours is recommended for these patients. So that's the evidence and then my experience as well.
I think when I'm communicating to GI colleagues, one of the things that I try to emphasize is kind of what you said, like this sort of, is this as good as we're going to get?
Yeah.
Like, there's a big difference between somebody who's still hypotensive, but like they've only gotten like 500 mils of crystalloid versus somebody who's hypotensive on pressors, despite, one MTP cooler, second one running in now.
Right. Yes. And
that's somebody where they're failing resuscitation as opposed to not resuscitated.
Totally. Yes, exactly. Yeah. That's, and I've had plenty of cases of that where they have the MTP going, and well, I don't know if this is a trade name or not, but the Belmont running, and we're pumping in blood in this person, and it's coming out both sides at once.
Yep.
And if I were going to wait for them to be, 120 over 80 with a heart rate of 60 to 70, they wouldn't have made it. And,
Right.
luckily I was able to go in, stabilize them. Ultimately, the best course of action for one patient I'm thinking about clearly from my fellowship time, he went to the IR suite almost immediately after we were done. We were able to locate the bleed and find it, and kind of a great outcome. I saw him in my like inpatient follow-up clinic like a week later, because he was discharged with no complications of his hospital stay. So that's what I mean. That's a great. It's a story that I keep with me of like waiting and waiting and waiting till the perfect time, you may actually miss your window of the perfect numbers. You may miss your window of opportunity.
So I know we want to talk about, first of all, that was great. I know we're going to talk about PPIs
Hmm.
and surgery and IR and all those folks, but I do want to just make sure that, this point that you spent some time on is really well understood and appreciated. It sounds to me, David, like it all really comes down to communication between the boots on the ground team and the endoscopist, the gastroenterologist, I should say the endoscopy team, which is like, obviously we talk to you and then you kind of talk to your team, et cetera, because what I'm taking away from this is that there isn't like the prototypical patient for whom you're coming in at 6, 12, 18, or 24 hours. It's very much like you've got to um, appreciate what's happening, feel confident in the, let's say, the ICU team that they are in fact resuscitating
Hmm.
aggressively and that they
Yeah.
either are turning the corner or they're not able to turn the corner, and that you're kind of the missing piece of that puzzle to turn the corner. It sounds like those are the kind of discussions that need to happen rather than like draconian rather than a draconian approach to this is the number and before it is useless and after it is the right time.
Yeah. I mean, that sums it up perfectly. Is that we're a team sport. Communication always makes things go better. Definitely.
So let's talk about some of those other therapies. So you mentioned PPI. You want to double click on that a little bit for us?
Yeah, for sure. So let's say you get this patient, this yeoman, gentleman, peasant, whatever he is. Um, when do you start PPI? I would say, again, start it as soon as you can. Now, if for some reason you can't get it started, it shouldn't delay, obviously, other resuscitation and or, the endoscopy. Surprisingly, though, this is something that I didn't know until I was a GI fellow, is that the PPIs themselves don't demonstrate necessarily a significant mortality benefit. The reason that they're used is because they actually help downstage the ulcer bleeding. So on that fourth scale that I was mentioning before, so from your 1A, 1B, all the way down your 2A, B, C, and then your 3, going from those higher stages of the 1A, 1B, so those are actively bleeding ulcers, it downstages them into ones that maybe have a clot or are not bleeding at all anymore. The first dose always has to be IV and it's always high dose. I always start with IV in these folks, even if it's like seems like a minor GI bleed, maybe not like our patient here, just because it's heretofore undifferentiated. 80 milligram bolus IV, and then you can start the drip. 8 milligrams for the standard drip, or you can do pulse dosing. In the last time that I've looked at the studies of this, I think it was just a non-inferiority study, and they're kind of non-inferior. One is non-inferior to the other. Don't quote me on the. I don't off the top of my head. I'll be honest. Know the.
That's exactly right.
Yeah,
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 so the there's a meta-analysis and there's a couple trials
yes,
and
yeah.
there's many observational studies that show that the bolus dosing twice a day versus the continuous infusion have
Mhm.
equivalent outcomes. So a lot of institutions, including mine, have gone away from the continuous and gone to that.
Definitely, yeah.
But all of the clinical trials that demonstrated that PPIs were helpful were all done with continuous. So take away from this what you will.
Mhm.
I think sometimes when you have limited access and you have to deal with like compatibility of different meds,
Oh, definitely, yeah.
sometimes
For you guys, that's so
it's
important.
really
Yeah,
nice. It's really
yeah.
nice to be able to go with bolus dosing instead of a line taken up by continuous.
Oh, I can imagine. Yeah, definitely,
Yeah,
definitely.
that's a really important point, that compatibility issue, which also just talking medications in general reminds me of something I wanted to ask you, David, which is, so are all these folks getting ceftriaxone?
No, no, no. I think if I again going back to like that clinically significant portal hypertension. Let's take this guy with his alcohol history. And thinking if I have cirrhosis, I will use it again if I'm have a higher suspicion that there was some previous um, portal hypertensive disease or cirrhosis beforehand. So that's where I'm looking at the platelets beforehand, maybe trying to get as much of a history as I can, knowing that sometimes by the time I get there, the patient already has been tubed and just kind of have to guess. But I would say for someone like him who, let's say we don't have any evidence that he has portal hypertensive bleeding, I would not necessarily recommend getting ceftriaxone in each of them.
Great. Yeah, I just wanted to kind of bring that up briefly because that's a learning point that I encounter a lot of times with my residents. Is like I get a call in a GI bleed case. Patient's got no history of cirrhosis, no
Mhm.
reason to suspect portal hypertension, but they're already on like ceftriaxone or like cefepime for some reason because they're like in the ICU. And I'm like, but why?
Yeah.
Here's another
If
one of
they're
those that I hear sometimes, which is like, this person's really sick. Should we call surgery?
Oh, no. So, the only time I would ever, and that's not to speak ill of the surgeons. That's not what that's for. I would call them if it like their bleed is from a perforation, yes, because that they'll fix. But in terms of surgical management of your run of the mill upper GI bleeding, so let's say like peptic ulcer bleeding, it's been proven in studies that have worse outcomes compared to endoscopy. The ones I'll actually call more for help is intervention radiology, and that's dependent on like your local capabilities. When I'm getting like these massive upper GI bleeds, I will usually on the way in or call them to make them aware. And then, will afterwards, let's say if I think that something's going to go bad, or at least I won't be able to stop the bleeding, or maybe they'll rebleed. They're high risk for rebleeding. I will let them know where I found the bleeding, such that they have a target. Or a lot of our clips are
Yep.
metal and are radio opaque, so they can be seen by them when they're doing their CT guidance. Otherwise, talking about, and this is just bringing back with this gentleman, and we're talking about IRs. The question always comes back of diagnostic radiology, doing a CT angio. I'll do it if there's hematochezia, maybe more, like I mentioned before, for lower if it helps speed up treatment or triage or at least localization of the bleeding. But I would not really push for a CT angio in every single obvious upper GI bleed like this person has.
I feel remiss that we didn't touch on this earlier, but no time like the present. We've mentioned several times this term of like a massive GI bleed. In the world of pulmonary medicine, we talk about massive hemoptysis,
Hmm.
and historically there have been a cacophony of volumes, estimated volumes that have been used to sort of say, oh, this person has massive hemoptysis. I think many of us, and if people want to go back and listen to our episode on massive hemoptysis, they'll get a chance to review this. But many of us sort of lean on, if the bleed is life threatening, it's massive. Is that sort of the same approach with GI, or is there a more specific definition?
Generally, I would say using a moniker like a massive for it would be that if it's causing some kind of hemodynamic compromise. Um, Unless you wanna sit there and measure how much is coming out of whichever orifice the blood and/or melena
Spin
is
it
coming from.
down and
Spin it down a little bit. Yes, yeah, right, collect it with all the protein and whatnot and the heme and the melena and get the exact volume. But yeah, I would say, more massive would be if it's causing any kind of hemodynamic, compromise for the patient.
perfect. Okay, that makes sense. So now we sort of underlined or otherwise fleshed that out. From a critical care standpoint, when I see patients like this, or generally when I see anyone with concern for hemorrhagic shock, I'm pretty worried when their hemoglobin is already low and they've got an elevated shock index. If we see that their systolic blood pressure is low, their heart rate is elevated, that's concerning for kind of advanced shock. Not surprising. There's also though a lot of discussion about looking at hemoglobin in the world of GI bleeds and other sort of bleeding conditions, and how that is a lagging indicator. So maybe we could just foot stomp that idea, David. Perhaps you could help us with this. The idea of the normal hemoglobin in someone who's got a BUN elevation and an active GI bleed. What do you make of that?
Yeah. Yeah, no, definitely. I wasn't necessarily I don't in my mind thinking about the shock index. Usually it's just kind of a gosh, that looks sick. But so, the often quoted threshold, which is now it's supported in the guidelines too, of the 7 of the kind of more restrictive transfusion threshold, the hemoglobin of 7.0, came from that paper in 2013 or 2014. Don't quote me on that. From the Villanueva, was a primary author on that. Actually, it's been well supported in the guidelines from there on, and maybe those in some of the guidelines from ACG recommend maybe in those with cardiovascular disease having a threshold of 8. Again, kind of a those are like conditional recommendations, lower quality of evidence, just given the paucity there is. And of course, there's like very little on patients with active ACS. Luckily, thank goodness, I don't think with this guy we're dealing with active ACS right now. But really important about the Villanueva one, and this is something I foot stomp with my fellows and with uh, rotating residents and whatnot, is that yes, we have the threshold of 7, but think about when you read the fine print, people who were excluded from the study. Those are people with, as I believe the term they use is like exsanguinating hemorrhage. So those with
Sounds bad.
hypertension, yes, very bad. Yeah, the really make your sphincters all tight and pucker up ones. Those with like hypotension, hemodynamic compromise from their bleed and the hemorrhagic shock from it. So, you know, if let's say we're this, guy that we're getting called on, if he starts getting even worse, and someone says, well, his last hemoglobin was 8, we don't really need to give him any blood. That's all. I'll say, well, that's kind of BS. He's hypotensive. If they're in, hemorrhagic shock, give them blood. Obviously, you guys are all the experts on how to do that, how to keep balanced transfusions, etc. So I'm not going to lecture you. Couldn't lecture you. I couldn't even dream of lecturing you guys on that. But for the listeners, saying that yes, even if there is that quote normal hemoglobin that's above our thresholds of 7 or maybe in some cases 8, keep in mind the patient in front of you and don't be so dogmatic about just this one number. See the whole patient. Obviously, you mentioned, Cyrus, the shock index, and just using your clinical gestalt on them as well.
Yeah.
Yeah, I think that's a great point and a key limitation of that study, which is often misunderstood, right? That like in that study, they transfused people who were unstable to stability, and they transfused people who were stable to a hemoglobin of 7.
Yes,
right?
exactly.
So we should do the same. We should do the same thing, right? If somebody is in shock and you're thinking about starting pressors for hemorrhagic shock, I don't really care what their hemoglobin was when you checked it an hour ago. I don't even really care what it is now. I think we should transfuse this person to stabilize them.
Actually, it's a quick anecdote. That guy who I was mentioning before, the patient who rushed in and eventually I saw in clinic a week later. I think the last hemoglobin before we started our AGD was from a blood gas or something like that. So kind of a surrogate, not a true, maybe the best test for his hemoglobin. It was like 10, but his blood pressure was systolic in the 80s or something. So we're continuing to run blood through him. So you could imagine how foolish it would have been if we said, okay, it's 10. All right, everybody, cut off the transfusions. Let's just we'll just see how he does.
Yep. Send the blood bank home. We'll
send him home. Yeah, get this cooler out of here.
Right.
Yep.
Yeah. It's all. As with many things, it's all about the clinical gestalt, right?
Totally.
Hemoglobin is just a number.
It is. It's also, that context is really important too. You talk about that study and the fine print. I think we talked about this too, where you're discussing the PA catheter, Nick, and how it's like, there were studies like Pac-Man and other ones where they were like, oh, well, PA catheter doesn't, improve mortality in critically ill patients. So I guess we just shouldn't use them anymore. But then you're like, wait a second. The really not so fine print in that study is like, there's a very, very significant population here that's not part of this trial.
Right.
So like you have to understand in depth the literature that you're hanging your hat on if you're going to apply those tools to your patients.
Frankly, for you guys, I mean, the population that's taken out of this, or at least not treated to those same thresholds, is the most important one. And those are the ones that you should be taken care of. So
exactly. This is not really an ICU study in that sense.
Exactly.
It's kind of like a medicine wards or study. So yeah, great point. Okay. As sort of as a segue here, maybe we should talk a little bit about as a proceduralist, what counts as resuscitated or stabilized? Like, let's say we've given a couple units of blood, the blood pressure has come up, the heart rate has come down, the shock index is now normal. What counts as stable?
Yeah, no. The most important thing to always remember when you're consulting GI about discussing stability is the sun out. Has the gastroenterologist had their coffee? Have they already finished scrolling most of the news and or Reddit or something? At least the front page. And
is it a holiday weekend?
Is it a holiday weekend? Yes, of course. The most important things. And I think that's really that. If I could take if they could take a few learning points from that, it's just do it at a time that's convenient. I'm just kidding. I'm obviously kidding. Let me put that out there. We're kidding. The things you just described, I mean, if his blood pressure had come up, the shock index was down or back towards normal, I mean, that's awesome. I would love that. I'd say, okay, let's go. But in terms of the literature and the guidelines, from the GI side, it's kind of all they say is, yes, resuscitate your patient before you start it. But that's where I'm working with, the ICU team and everyone else involved too, to say, okay, is this, how much have we done thus far? And as we kind of mentioned before, is this the best we're going to do? Is there something where, hey, maybe we could get them better, without delaying too long before we get definitive therapy, or at least maybe if I'm not giving definitive therapy, at least some diagnostics as well to guide whomever may be able to give definitive therapy. So it's all just about finding that sweet spot and working together to get it. And so, yeah, me as a gastroenterologist, I'm not too draconian about wait till I am at the most convenient time for me, or I'm going all the way up to those 24 hours. If it's been 6 and the patient's doing a lot better, and I think, hey, this is the time to do it, we'll do it.
Great. And I think just help me understand here. So the thinking is basically you want them stable enough that that you can do the procedure successfully,
Yes.
so that you can diagnose what's bleeding and maybe intervene. If they're
Yes.
unstable going into the procedure, we can't sedate them adequately for the procedure. You may not be able to complete the procedure.
Yeah. Sedation. And then I'm worried about, let's say, in terms of my differential diagnosis, or for this gentleman, let's take a ulcer. Let's say maybe the PPI has worked a little bit. So he went from a Forest 1A, so active arterial hemorrhage shooting across my screen. And now he has an adherent clot or something, but I know it's pretty high risk. So he's like in the kind of 2B range, or maybe he has a non-bleeding visible vessel. So 2A, those are the ones that actually really get me nervous as well. If he's not fully resuscitated, and let's say there's something that goes wrong with my procedure. So, a clip misfires, the vessel starts bleeding. If he's not fully resuscitated, then he starts losing blood, and we artificially, or maybe iatrogenically upstage his ulcer back to a 1A, and he starts losing blood at that previous rate. Well, then we're going to be in some trouble. We're going to have some real bad problems there.
So you like to see a little bit of cushion, so it's a little safer to do.
A little safer, yes. I'm personally, for me,
Gotcha.
the cushion, having my contingencies, knowing that if something should go wrong with this, that I know this patient will stay safe. And as you mentioned with sedation, super important for me, because if someone is retching, trying to wiggle around the bed, I've had times doing an EGD on someone who they're using their hand to kind of punch me in the stomach the entire time. That makes it a little difficult to get a complete exam, shall we say, and to make sure I'm assessing the mucosa that I'm supposed to be able to be assessing properly the first time around. So.
Yeah. Oh my gosh. Yeah, that sounds not fun, to be.
It was interesting. It was very interesting time.
Is this painful? Is this?
Yeah, right. Yeah. How does that make you feel? I'm trying to be a humanist when I ask that.
Take that, gastroenterologist.
Yeah, right.
So just as an aside, again, I think there may be a few gastroenterologists listening to our podcast, but most of the folks are people who are on the resuscitation side of the equation. And so one thing I picked up working in trauma ICUs was using the base excess, which is present on really any of your blood gases, which isn't really that magical. It's kind of just, it's a quick reference, and it's easily trended if you so choose to trend it. It can be helpful in identifying folks that have a metabolic acidosis that is not just due to an elevation in serum lactate. So of course, if these patients are left to their own devices, we would expect them to have, a type A lactic acidosis, a classic lactic acidosis. But a lot of times their situation may be a bit more complicated and a bit more nuanced up front, to where the base excess, being a very, again, sensitive measurement, can drop. So in other words, it's a base deficit. So we think about normal being -2 to +2. So if they have a evolving base deficit, you may actually see that, and this is according to some of the traumatologists that I worked with, you may see that as sort of this semi-early indicator that the next thing to drop is going to be their hemoglobin. And so I've used that before with success. Again, this is probably like level Z 4B subset A evidence. I mean, point being is that it basically, I think, is something that might get you resuscitating more aggressively sooner, which is never really a bad thing for someone who's exsanguinated.
Yeah, I think it's a great point that, like, if somebody's base deficit has normalized, that's yet another indicator that you have achieved your resuscitation goal, at least for the moment.
Yeah, absolutely.
So
So
it's also probably worth emphasizing this is dynamic, right?
Mhm.
That it's not like check the box, we're done. It's like, okay, right now they are, but like in 3 hours they might be sick again. So it can be evolving.
Absolutely. So okay. So we'll get back to kind of you, David, and get towards the end of this case before we pick up our second and final case here. So, let's say now that we're all in agreement that the patient's been resuscitated, their shock index is approaching 0.7 as opposed to being greater than 1. Heart rate's looking better, blood pressure's looking better. kind of slowing our resuscitation efforts. And you're like, okay, cool. I'm ready to go. I'm ready to intervene. And now you're kind of at the bedside. So we talked a lot about communication. And so I guess one riff off of that would be when we talk about boots on the ground teamwork between you and the ICU team. What does right look like? Maybe if there's anything you can leave our guests with on that front. And then I don't want to get too far into the weeds, but I think it would be nice just to maybe briefly review the tools that you might have at your disposal to manage the non-variceal GI bleed. And if any of those tools are maybe associated with, I don't know, post-procedural concerns, complications, what have you, that we as the intensivists monitoring those patients need to be aware of. So kind of two parts there.
So we're getting almost to the part that I find most fun. Okay, all right, good.
Almost, yes.
Almost.
I had to throw you a bone.
Yes,
bone.
of course. Yeah, something. But yeah, I mean, the good communication beforehand. Obviously, I'm always talking to my ICU team before of like, maybe we're talking about hemodynamic goals, transfusion goals, obviously asking nicely for intubation early on, and then letting them know what I'm thinking and what I'm anticipating finding. So whether it's a non-variceal upper GI bleed or just another upper GI bleed, and what maybe I'll do for each problem on the differential. So using some of the tools I'll talk about in a little bit. And of course, like if I feel that the bleed may require another expert to weigh in or do some other interventions on, so like saying, hey, would you mind giving IR a call? I'm going to go down and take a look at this, and I can call them later, but I want them to be aware of said patient before we get rolling, just so that we can have a more effective handoff there. I think one of the really great piece of advice I got from one of my attendings in fellowship, and when I was in fellowship doing the ICU cases, and I being program director of the same fellowship now, it's a stressful time. A lot of people running around, a lot of people doing everything they can to do what's best for the patient, and blood is pouring out of places, and so it's a really high stress time for everybody. So the best piece of advice he gave me about effective communication was just having a time to kind of slow down and make sure that everybody knows their job and what they're doing, and that everybody else knows every other person's job. So we always have to do a timeout before every procedure. So, this is Mr. So-and-so, date of birth, yada, yada, we're doing an EGD. But during that time, it would be run by the endoscopist, or, for us, it would be the fellow running it. After we do the normal things, confirming patient and consent, stuff like that, he would say we'd go around the room and we'd say our roles. So, I am so-and-so, I'm the GI fellow, and I'd say I'm David, I'm the gastroenterology attending, and then, this is the ICU fellow, this is so-and-so, the ICU nurse, this is the RT, this is the person, running the Belmont or something like that. So then we're all aware of each other. So it takes less than a minute to do, but I find that's so effective for rapid communication rather than saying like, hey, you, or, trying to get somebody's attention, say,
especially since everyone's got gowns on typically.
Yes,
so you can't
right. So you can't see badges.
So
You're all like, and sometimes if it's really massive GI bleed, I'll have the face mask and goggles on because I don't know what's coming up into my face. So just say like, hey, someone's name, or someone says, hey, David, are you seeing this, or there's blood coming from here, or something like, like that, then we can communicate far more effectively. So that's what I think the best kind of teamwork in my eyes has been. When we get to intervention, so man, this could be a whole several hour long podcast on this.
Go for it. We'll just edit it out afterwards.
Perfect. Yeah, we'll just crap out. You'll see like the sunset in the background, and Nick and Cyrus will be like asleep around going. Yeah. Oh my God, what happened to them? The old adage, and this is the best evidence base, that for us, when I say I'm going to talk about ulcers, 2 interventions are better than 1. So always, I'm injecting an epinephrine solution into the submucosal space, generally around the lesion, around the ulcer itself. And that's where you can see actually sometimes if it gets into the more systemic circulation, an increase in heart rate, maybe an increase in blood pressure a little bit, depending on how much we're using. But in the area itself, the benefit is that if it was actively bleeding or is high risk for actively bleeding, the mucosa around it will blanch out at that point, which makes it just easier for visualization. So in terms of our intervention that we can use, we have clips, we have cautery of various kinds, APC, which I think the Palm uses as well, and then the more recent
APC is argon plasma
Oh,
coagulation,
yes,
by the
sorry,
way,
yes,
but
argon
yes, yeah.
plasma coagulation, yes. And then the most recent thing that we've added is the hemostatic powder. So the clips themselves, there's a couple kinds. There's an over the scope clip that kind of, those bear traps that like in cartoons they step on and it, so it's like that, but it goes over the end of the scope and you suction the ulcer into the cap that has the clip on the outside of it. As the ulcer is suctioned in, basically we turn a wheel on that's added to the scope on an attachment. It pulls this string that pulls the clip off and it grabs the ulcer bed or just the normal mucosa around the ulcer bed and closes that area. And of course there's clips that we have that we send through our working channel of the scope as well. Most of our other instruments, so the bipolar cautery, monopolar cautery, which isn't used super commonly anymore, all go through our normal channel. Then just as an aside about the hemostatic powder, so those are actually, it's not like a thrombin or any factor, any factor like product. It's really just an anhydric, non-biologic. In one of the formulations, like a powder that really just assists and gives kind of a lattice work for the clot to eventually form in those areas.
This is like the GI version of quick clot, is that right?
In a sense, yeah, it doesn't have any like factor or anything in it, but yes, it's something very similar to that, yeah. And it's actually really cool. The way it's given, at least one of the formulations is it's this little gun that has a small chamber where the powder is, and then there's another chamber that has basically a CO2 canister from a paintball gun or something similar. I'm sure it's far more expensive because it's medical grade, yada. But you twist that, you puncture the CO2, and then your tech will send it down, and you'll tell them where to spray it, and you can kind of paint it on there. That's for like severe refractory bleeds and malignant bleeding. So if someone has a gastric or other cancer that's causing bleeding, using cautery, using clips will not be beneficial in those bleeds because again the disordered vasculature of them is so fragile that using these mechanical or cautery based methods of hemostasis will only make them bleed more. So that's where the uh, hemostatic powders will come in. And then finally, the last thing you'll see sometimes if you're in an ICU setting, you'll see the gastroenterologists have one or more scopes hanging on. Really, the sizes is based on the size of our work, the working channel through there, and it's meant to clear the blood and or clot faster. So the first one that I'll use is our regular gastroscope. That's like your EGD scope, the one that we use. That has a channel diameter of 2.8 millimeters, so I can fit like 7 French instruments through it very easily. But again, the largest one that we have, we call the XT, or in my unit, it was lovingly referred to as the clot buster. Has a working channel of 6 millimeters. Some of those both sounds really small, but keep in mind that flow is quartic to the radius, or it's a radius diameter, whatever. I guess they're functions of each other, but it's quartic to the size of the working channel. So being nearly double the size, quartic, that's about 16 times faster flow through it. There's one in the middle that's like our what we call therapeutic scope, used for more complex outpatient therapeutics cases, but has a working channel of about 3.7 millimeters as well. There's other suction devices that bypass the scope entirely that we can use. Again, don't want to belabor these points, but if you do see them switching out scopes or anything, that's what they're doing, is trying to clear blood, clot, whatever may be hanging out in the stomach a little faster.
Nice.
Great. Okay. Nice overview. You kept it under an hour. That was excellent.
Yeah, we cut out the middle 45 minutes, but yeah.
Yeah, that's right. Like the sun is set now.
Yes, right.
So now I guess that you've done this procedure, we've resuscitated the patient, you're washing your hands, about to go home, and the question comes up, how much longer do we expect this patient to have melena for?
Yeah. Well, I'm glad it worked. I will always say in my reports, especially for the massive upper GI bleeds in the ICU, the melena will continue. And that's just what's going to happen. I can't necessarily give a set day of when it will or when it won't stop. Sometimes I've seen as long as 2 or 3 days. And of course, also as the patient's intravascular volume kind of reequilibrates from the interstitium, you may see the hemoglobin drop as well. A little bit of time, obviously not briskly. So then, like, am I going back to scope everyone? Like, certainly not. And as we mentioned before, the BUN, that's what then the subsequent days I'll be trending that if it was an upper GI bleed. And if it's downtrending despite continued melena, I could more confidently say that, like, yeah, this person's probably not, most likely not having a rebleed.
I think that's a great point. And I think this is also the time when Villanueva maybe does apply a little bit
It
more,
does, yeah.
that like a lower transfusion threshold after you've resuscitated them and they're stable. Yeah, absolutely. Target 7.
Oh, certainly. Yeah, yeah. That's excellent point. Excellent point. But I mean, we're not perfect. Rebleeds happen. So that's where, current guidelines, I guess the question is then like, okay, you failed once. Why would I even want you to go back in again? So, current guidelines are the evidence for far fewer complications of surgery of doing, a repeat endoscopy. Now, there haven't been any repeat or RCTs or good quality evidence comparing like me going back in again versus just saying, hey, let's just call IR. This guy's a joker. He messed it up once. What the heck? Things where I may be more inclined to say, "Hey, it's probably better if I call IR rather than, put my ego aside and say, hey, let's let them do their thing." If maybe the index endoscopy was a little more complicated, or I used an intervention that's really difficult to revise, like one of those over the scope bear claw, bear trap kind of clips. The benefit is that when I do call them, of course, if it's just that one lesion, I can say, okay, it is in the, you know, between the first and second portion of the duodenum. It's on the posterior wall. Okay, maybe I would recommend you guys shoot the GDA first and see where that can give you if that can give you the most bang for your buck. And of course, if the patient rebleeds again, is hemodynamically unstable, then I'm really more inclined to call IR rather than kind of take a second look in there.
Yeah, that's a great discussion, and I think that was a big case that we took you through with that upper GI bleed. But I think we touched on a lot of points. The big themes I'm taking away from that are communication is key, teamwork is essential if you're gonna take care of these patients. Getting those index labs and then trending those labs appropriately,
Mhm.
but not being, reactionary if a number is moving in the wrong direction, but everything else is looking right and appropriate. Specifically when you're, looking at maybe that hemoglobin has yet to nadir, but hemodynamically the patient is showing signs of improvement. You as the endoscopist feel very good about the intervention, et cetera, et cetera. But then recognizing too that not every intervention is going to be perfect. And sometimes you're going to have to call on some of those additional team players, whether it be the interventional radiologist or, if all else fails, the surgeon.
Mhm.
Assuming that this is a person for whom repeat endoscopy maybe isn't the best option.
Right. Yeah. Exactly.
So that was, I think, a great discussion. We have kind of one more case I wanted to talk
Let's
about, which
do
I
it.
think is can kind of considerably shorter, but is going to help us hammer home some of the last points that maybe we didn't get to with this first case. So this is going to be a 72-year-old lady who's got a history of hypertension, chronic kidney disease, let's say stage 3 CKD, and she's got atrial fibrillation, so she's on apixaban, and she's coming in with painless bright red blood per rectum that started this morning. She denies any abdominal pain. She's not complaining of any nausea or vomiting or really changes in her bowel habits. She's hemodynamically stable on presentation. So she's like 130/75. Heart rate looks good, 82, 85, no fever. Her rectal exam that you do at the bedside confirms that she does have bright red blood without any gross clots. And her hemoglobin at time of evaluation is 10.2. Previously, she had a hemoglobin at 12.5, so not a huge drop. I think there may be a few interesting points to suss out. And again, this isn't necessarily a patient who's immediately going to go to the intensive care unit, but we may get consulted on them. We may get involved in their care. So I think it's still relevant. In terms of how we might approach this patient, David, if we, the royal we got a call on this case from the emergency department, how might you approach them? What questions might you ask? What might be your initial concerns, et cetera? How do you look at a case like
Of course, right, she's stable. I'd roll over and go back to bed first. But,
that?
but
There you
no.
go.
So
I said it was a short case.
there we go. Yes, extremely short. Okay, yeah, bada bing,
Easy.
bada boom. We're done. Outpatient now. So I guess the first, question with some of these, and this has changed a lot, or changed in recent years, is what we do with while they're in the ER. Do I get a CT? Or sometimes the ER will get a CT angio already on the patient, which is great if they do. I won't demand it. Sometimes I'll say, hey, maybe we should get it if I'm thinking that it's clear lower GI bleeding from that case. If there's active bleeding, if the CT's already been done, particularly if it's in the more proximal colon, so I'm thinking like the ascending or something, I will, by the ACG guidelines, and I'll push more now is to call IR, see if they want to take a crack at fixing it. Given that she's hemodynamically stable, if she's already admitted without CT angio, I'm not going to be too upset about it based on the guidelines because of her stability. And of course, to get the CT angio to make it actually worthwhile, they must be actively bleeding. So she seems like if she's presenting with this bright red blood pressure, it kind of came on very quickly, that we may be able to find something from it. Now, if she comes in and says it's been for a couple days, I've just kind of slowed down recently, then I'm not wasting everybody's time with the CT angiography. But most importantly, with her, I'd say for the differential diagnosis you mentioned is that for her, I mean, it just screams diverticular until proven otherwise. We have an older patient, painless, bright red blood per rectum. She's had a good drop in her hemoglobin. Seems like it could have been quite voluminous in its the amount of blood that she's been losing. So that just screams to me that's a clinical situation, or the illness script, as some I've heard it referred to as, of a diverticular bleed. So fast on, lots of blood, and then may stop. Certainly could be from like an AVM. But when I'm talking to her, or maybe before I start my scope eventually, I'm thinking this is going to be a diverticular bleed.
Awesome.
Okay. And so this person's on anticoagulation, right? They're on Pixaban for AFib. What are your thoughts on checking coags and B reversal?
Great question. So right now she's stable, so I'll hold the Apix and tell them to stop it when she comes in. Reversal has been something that's kind of changed a lot recently. So, well, I guess we'll take one step back to doing traditional coag assays. Again, this will be really more interesting to talk about coag assays in the variceal hemorrhage talk. So we'll kind of just table that for now. Certainly, if she gets one on admission, I'm not going to be too upset about it in terms of like an INR or anything like that. The big question is reversing. So for Pixaban itself, just the ACG, and actually is the from our friends to the north, still our friends, hopefully, to the north, the Canadian Association of Gastroenterology is actually against routine reversal agents, since one, the significant cost, and the present evidence for patients who are maybe hemodynamically stable for reversing apixaban. The quality of evidence is rather poor. You could consider in someone who maybe if they're still taking the apixaban and they've had it within the last 24 hours and it's like a massive life-threatening GI bleed. So not this this person in front of us. So I really don't use it in routine practice for everyone there.
It's kind of the rare case where it's a really big bleed, which
Yeah, a rare case, really big one. Now, depending on your availability of if you're able to get the reversal agents or not. Obviously, if you can't get the reversal agents because they're prohibitively expensive, it's still recommended, PCC much over an FFP or something like that.
Right.
Nice. Awesome. Okay, cool. That's helpful. So I think, this is a patient who pretty clearly has some ataxia, but I guess in maybe more subtle cases of the lower GI bleed, let's say they have, questionable melena. How do you respond to the enterprising resident who calls and kind of proudly says, oh, well, we did the rectal, we did the FOBT, it was positive, and now we really need you to come in and scope this patient. And as an aside, other than this kind of omnipresent FOBT, are there calculators similar to what we discussed previously that we can use for lower GI bleeds as opposed to those upper GI bleeds?
Yeah, for sure. So I'm going to table the FOBT for just a second. That's a common thing I get. But in terms of what the data is, there's a little bit more paucity of data for lower GI bleed scenarios, to assess these clinical decision tools. ACG suggests using the Oakland score. So certainly that's a fine one to use. Again, I'm not living and dying by it, as we kind of had discussed before, but that's one you can consider using. The FOBT. So
well, that's fecal occult blood test.
Yes, fecal occult blood test. Yes. So first of all, don't if the patient has blood or melena, and it's clearly melena coming from them, there's nothing really occult about that bleeding, right? So you don't need to use an FOBT, right? It's a obvious blood coming from there. If they had some previous blood or they'd had some previous melena, and then the FOBT was positive, and they're going to be admitted for that or for some other reason, then yes, I will see the consult and consider endoscopic assessment if it's required. However, taking it back to our patient we mentioned here, if someone called me about her and said, hey, I got an FOBT, be polite, smile and nod, but
Uh-huh.
then say that was a complete waste of time for the actual PT to be done because there's nothing occult
Yeah.
about the bright red blood coming from her rectum.
Yeah, that's
And I
definitely
think
not a
I
cult.
think, you know,
Unless it's like in a
getting
pentagram or
Right,
something,
yes,
then it's a
yeah, that's
cult.
what I was gonna
exactly.
say. Like, it subscribes to witchcraft and wizardry.
Right.
I mean, I think people sort of have decided for reasons that don't make sense to me that this like outpatient colon cancer screening test
Yes, that's
has
yep,
utility in like GI bleed assessment among inpatients.
yeah.
And it's never made any sense to me, but yeah. I
That's it.
mean,
You bring up an excellent point there. Is that that's something that again what I will harp on with my maybe not the fellows, but at least with the rotating residents or something like that, is that using this, it's a colon cancer screening tool only. That's what it's been validated for. So just like our clinical decision tools, just like any test you run or scoring system or whatever you're using, make sure you know what it's been designed and validated for. And so this isn't a hey, let's try to find the bleed by you know poking around the rectum and maybe there's some hemorrhoids there or anything like that, or try to prove to the gastroenterologist that he or she should rush in the middle of the night to bleed to scope this person. Um, it's just an outpatient, primary care screening tool.
Awesome.
so getting back to the case, let's just say that this patient, while they're in the ED, they start to decompensate. They start transfusing them. They call the ICU. They say, we're gonna have to upgrade this patient to ICU from wards. From a GI standpoint, how should the approach be different now that this person has gone from being kind of stable with
Mhm.
painless rectal bleeding now versus unstable? Let me ask you one more question because we have to hit you with 4 questions at
Of
once,
course, yes,
apparently.
please.
Would you give this person TXA?
Oh yeah, okay, good questions. Good questions. So I guess first thing is what would we approach differently? Again, very similar in terms of the resuscitation for an upper GI bleed. All of the same principles kind of remain the same. Other things that have kind of come up, um, from the guidelines, you would say like, okay, why don't you just go in? Like I already mentioned, blood is a great cathartic. Shouldn't that move whatever's in there through? And you should be able to do a colonoscopy right then and there, or maybe once they get a little more um, resuscitate or anything like that. So ACG guidelines, they waffle on this a little bit. They do mention you could consider a unprepped flexible sigmoidoscopy if they've already had a colonoscopy within the previous like 12 months, um, and that there is sigmoid or at least distal diverticulosis. Someone who's at least in the GI world is has really pushed for this in the past, and that's a great Twitter handle to follow because it shows like really excellent GI bleeds is Andy Tao. He's out of Austin, Texas, Austin Gastro there. On Twitter, he's at Dr. Blood and Guts. For those of you who want to see some really cool videos of bleeds that even though I'm not the one scoping, I'm nowhere even involved in this person's care, but watching them always scares me. He's someone
Hmm.
to watch. So please go check those out. It's something to maybe consider if I know if this person has had a previous, full colonoscopy on as an outpatient, not in the bleeding scenario. And I know this sounds like a diverticular bleed and it's something maybe I could get to pretty quickly. Then maybe I would consider doing an unprepped flexible sigmoidoscopy. Otherwise, if I don't have that information and they start to become unstable, now, hey, they may be actively bleeding. This may be the time if you can get them to the CT scanner would really help out myself and or interventional radiology in figuring out what the best next step in treatment is. And then there's TXA. So,
Which you're clearly a huge fan of.
no, I mean, it'd be interesting it'd be nice to use it. It just hasn't really flushed out in our guidelines. So the ESGE, our European colleagues, recommend against the use of TSA. ACG didn't even really put in as a recommendation in their more recent 24 lower GI bleeding guidelines. But there's a pretty big trial on this is upper GI bleed patients. The HALT-IT trial from published 2020 in the Lancet. RCT with about 12,000 patients showed no changes in death. Their primary endpoint was death and upper GI bleed. So like good, okay. But there's a lot of other things different in there too. So on secondary analysis, there's no difference between the TXA and the non-TXA group in terms of rates of therapeutic endoscopy. Which just to break that down, what that means that between if you get TXA or not, needing to go in and do an intervention on a these are upper GI bleed, so high risk ulcer lesion or upstage ulcer lesion was no different between them. And to give, I guess I should have talked about this earlier, but to give this more insight, ones in which I will the evidence states that I will intervene upon for an upper GI bleed are forest, 1A, uh, 1B, and 2A. So that's arterial bleed, venous bleeding, or a non-bleeding visible vessel. The 2B, so that's an adherent clot. It's kind of like a little it's wishy-washy, and those are kind of the question mark ones. And then the ones where there's no good evidence to do because the rebleeding rate is so low is the 2C and the 3. So 2C being having a little flat pigmented spot, and then the 3 forest having a clean based ulcer.
Got it. I'm just gonna say something quickly about the TXA literature because I
Mhm.
think like it's interesting, right? That like TXA is beneficial in trauma, it's beneficial in obstetric bleeds, it's beneficial in pulmonary hemorrhage, but it's not beneficial in GI bleeds. And why is that? And I think my take is that um it's beneficial when it's given early and it's not beneficial when it's given late. And it's very easy for us to be like, when did this trauma happen? When
Mhm.
did this obstetric bleed begin? When did this person start coughing up blood? But we're often vague about when a GI bleed began because there's this kind of inherent latency from like when it starts to when we see it. And so I kind of wonder if the reason why TXA is kind of meh in GI bleeds is because we don't know when we're giving it early and when we're giving it late. Anyway, no evidence behind that position. That's just sort of me sort of hypothesizing.
I really think that's yeah, because it's one of those things I've seen it more and more come, you know, as you mentioned, to be beneficial in all these scenarios, and I'm just always been thinking like, what is what is the problem with the GI system? But yeah, you're right. Is that if it's an upper bleed, whether massive or not, it takes time to fill the stomach to come up through hematemesis or to travel through the entire GI tract as melenic stool, or even a diverticular bleed. Like it's fast on, but we don't. It may take a while for the patient to come in or for the bleed to really get to that significant volume at which it we could they would seek care and be able to obtain the TXA. So I that's a excellent thought though. I wonder, with and I haven't reviewed this in the halted trial of, you know, at what our point of, and that's just presentation, not obviously knowing that the true genesis of the bleed, but at what point of presentation they were getting the TXA. And that's something I'll have to look
Yeah, I have to
into.
go back
Yeah.
and look at that too, actually, now that you say it.
Yeah.
So while we're looking at that, and maybe Nick, you can circle back if you come up with anything. But just to sort of get to the end of this case, let's say we spoke it to IR, we talked to general surgery too, so everyone's aware of the patient, and for whatever reason they because they've been worsening and we're starting to think this is a life-threatening bleed, we decide to go ahead and reverse their apixaban, and so things are looking a little bit better. We feel more comfortable. Been about 6 to 8, maybe even 12 hours of relative stabilization, or a period through which the patient's been just kind of getting better. So with that kind of in the background, I guess kind of just one procedural question, because a lot of times we're the ones that are going to put these orders in. How would you prep this patient? Like they don't have the luxury of like drinking all this go lightly at home. So how would you prep them, and how important is that prep in the setting of a more urgent sort of colonoscopy?
Yeah. So actually, the exact same way, it's still recommended to be the 4 to 6 liters of the polyethylene glycol, or like I'm going to use the trade name that we use, like Go Lightly or something like that. Prep, you know, it's not necessarily imperative, but it can be recommended or suggested to use the split dose of prep. So 2 or 3 liters at one time point, and then let's say I'm going to scope them in the morning, then the 2 a.m. running it back in. If they've been for some reason unable to complete the prep PO, you can obviously drop an NG tube and have it running through that way, which I'm sure you guys um, have all seen before. But the prep is really important to do, and to do at least, you know, as best that we can. I am very cognizant of that. It's the inpatient setting. These people have other things going on. They're pretty sick, and what my indication for the scope is. So, as long as I can safely get through the colon and see into, let's say, it's a diverticular bleed, into each of the diverticuli to look for sigmoid of recent bleed, so I can get a cleared clot, a visible vessel, anything of that nature, then I will proceed, even though if it's not perfect, to rule out like the 1 millimeter tubular adenoma or something of that nature. in terms of timing, so I would say I prioritize the prep in terms of timing, as long as they're stable and not necessary and not repeat bleeding or having any other evidence of hemodynamic compromise. There's not great evidence of like it has to be within 24 hours or anything like that. So I will, to do it properly, do it safely for the patient. If they've now been stabilized, I will prioritize getting a good prep in on the patient so I'm able to fully assess the mucosa of their colon.
Great. And so just to be clear, so what this means is that like if somebody was quote due for a colonoscopy anyway, if you give them an adequate prep and you're able to do this, that sort of counts as their um
I probably wouldn't count it just given that it's,
mm,
in this kind of setting. Um, that, other people may have different thoughts about that. I find that the inpatient preps are a little bit more are worse than the outpatient one. So it's very rare that I've had one that's so good that I could say, okay, this is makes a good screening colonoscopy for them. Again, that makes sense. You may be in the ICU or at least just on the medicine ward. You're not in your home in your own space where you're able to get up as often as you can to use the restroom. And then taking, of course, as I mentioned, the risk factors of these lower GI bleeds, diverticulosis, anticoagulation, antiplatelet medications tend to accumulate in older patients who may have
mm,
mobility issues or other kind of debility that's preventing them from getting to the bedside commode or to the toilet. So maybe they'll be less inclined to take the prep fully and as aggressively as
mm.
someone who's between the 45 to 75 range and doing this just once every few years or so. So it's very rare. Personally, for me, I haven't seen many great inpatient preps where I'd say this will count as your screening one, but leave that up to their gastroenterologist. And generally, I would say even if it's quote good enough, I still want to do them the service on the outpatient side of saying yes, I can now when I'm looking only for polyps. I'm not worried about your bleed or anything. Say that yes, we've done a good good job, right, and done right by you by screening properly.
Great. Okay. Perfect clarification. And then can you walk us through kind of your approach procedurally? Are you using that like clot buster giant scope
Oh
for
yeah.
these cases, or do you approach these differently?
Yeah, so the clot buster unfortunately is just an upper scope, so it's only it sounds like it's very long,
Mm,
the 100 centimeters long. So in some patients, you may not be able to reach the cecum with it.
mm,
Now you certainly can with. I've certainly gotten to the cecum plenty of time to toot my own horn with a gastroscope or something in patients. So like an upper scope, it's not difficult to do. But usually with these patients, I'm using our standard colonoscope. We do have a pediatric size one that's slightly smaller in diameter, has a slightly smaller channel, but otherwise once we start, although it may be a different scope, all the tools that I mentioned are very similar as the upper GI bleed. In fact, all the tools and the catheters that they're on can fit through either the upper or lower scope because they're all about 2 meters long. And the upper scope itself is about 170 centimeters with the attachment, and where the channel goes in is about 180 centimeters long. So that's really that's it's a very very similar itself in terms of other tools that I may use or like hey maybe getting like radiology involved or something like that. The bleeding rate really determines how well the radiology studies or which ones I pick. Again, if someone's in the ICU, we're thinking just a CT angiogram is the way to do. If it's a little bit of slower bleed, again, it can be much more sensitive if it's a real slow bleed to do like a tagged red blood cell scan or something or some other kind of scintigraphy of that nature. But we've all seen the pictures of a red blood cell scan, and the radiologists are really in nuclear medicine is very good at finding these things. But to me, it just looks like a total jumbled mess with a little flash of red
I'll
somewhere.
just also say that in my career, I've seen exactly one positive
Yes,
tagged RBC scan that was useful.
yeah, mine that has a little bit of observer or like bias from my world, but yeah, it's very few that I've seen actually be useful as well.
Yeah, it's a very thin sliver between too little for a CTA to detect, and it's still there.
Yes,
That's kind of what it's useful.
exactly, and it's still significant. It's something that we may be able to act upon. Now, if we get to the end and there's other things, and I mentioned that whole area of small bowel between the ligaments of Treitz and the ileocecal valve, or maybe at least the most distal part of the terminal ileum that we're able to see on a colonoscopy, all those things in there. So of course, you know, I would tell the learners keep in mind the kind of the weird stuff like Meckel's, AVMs. Of course, I mentioned AAA repairs as well. I think one of the most or any vascular intervention. I think one of the most dramatic cases that I saw as a fellow was someone coming with large volume thyroid blood for rectum. We prep them, we do the scope, and as we're going through, between their sigmoid and their descending colon, they had gotten um, you know, taking it back in their history, they've gotten stenting on their femoral arteries, and we're going through there and we see a stent kind of eroding through the wall of the colon there,
Yikes.
pulsating at us, not actively bleeding, luckily, but that scared the what out of us. We came right back and
Kind of
full
back
vascular.
out of the room
Like,
slowly.
whoa,
Full
okay,
vascular.
this is not our thing to deal with. Because there's someone else who can help them a lot better than us. But again, keeping in mind all those other parts of the history too, to see if there's maybe other testing that is useful or beneficial, either pre endoscopic evaluation or post endoscopic evaluation, if that turns out to be a negative test.
Awesome. That's amazing. Hey, Nick, did you happen to find anything from Halt It?
Yes.
All
So there
right.
is this is figure 3. They did break it down by less than 3 hours from onset, where
Mm,
there's a trend towards benefit, and greater than 3 hours, where there's a trend towards harm. So it's not significant because the less than 3 hours group is so small.
yeah.
But I wonder if you did a larger study, maybe you segmented it out a little bit more, maybe you could find something to support this wild idea I have. I don't know.
Nice. Well, that's very
Anyway,
cool.
TXA, darling child of the emergency department and the ICU, but not in GI
Not a
bleeds, I
GI,
think
yeah.
is the bottom line.
All right. Well, this has been a wonderful first foray into the world of GI bleeds. I think we've covered a ton of extremely important content. I kind of reviewed a lot of it earlier in the show, but just again to briefly recap, we've really focused here on those non-variceal GI bleeds. We've talked about the different causes for them, and then kind of the what makes a massive non-variceal GI bleed. Specifically, David, you mentioned hemodynamic instability, what you're worried about, which I think we as intensivists would agree with. And then, next you're really focused on some of the key tenets of management. One of which being communication, which maybe first and foremost between the endoscopy team and the ICU team. And then, making sure those patients are appropriately resuscitated so they can undergo your intervention, so they can kind of tolerate the sedation necessary and ultimately have a good outcome. Certainly touched on a whole lot of other really important content in a way that I think is a bit unusual for podcasts in this space. So I'm really excited that we got to do that. David, we certainly appreciate your time and your diligence with helping us put this together. We really look forward to you coming back and talking about variceal GI bleeds and cirrhosis with us in the near future. Before signing off, thank you again. And then anything you'd like to kind of plug or anything you wanted to promote before we let you go.
Well, sure. I'd like to plug the bleeding vessel. That's usually what my job in
Fair,
this is. Yeah,
fair.
yeah. No, the excellent summary. I mean, it's about. I don't know how much I can offer in terms of resuscitation, but at least providing the insights as to what your endoscopy team is looking for and thinking before we get in. So hopefully, I gave some educational points for everybody, and it's gonna be really fun to come back and talk about varices and all the crazy stuff that happens with them. I say if I could give a challenge to any of the learners or if there's people who are research minded. One thing I've always been fascinated about is when we're talking about these bleeds, and we mentioned anticoagulation, particularly apixaban for AFib or something like that. I've seen posters of this at our GI meetings. But I'm really interested if hopefully someone will do this study at some point. I don't know if I have time, but of following people who come in with recurrent diverticular bleeds forward and seeing outcomes of either stopping their anticoagulation or continuing it. So that's always something I've thought about, is the repeated admissions for some of these elderly patients and the debility and risk that comes with that. And maybe if there's a more practical way uh, we can think about their risk assessment for obviously the issues with stroke and why we have them on the anticoagulation in general, but also the risks of continuing them on potentially lifelong anticoagulation. So that's something that I talk about with my patients, I have my fellows talk about with them, and then on the brief occasions when I'm attending on the medicine ward teams, I will kind of discuss with them. So then I would challenge someone to do that research, but also encourage the learners that are listening to this to look into that and really get yourself in that situation where you can talk to your patients about this and maybe make some changes to prevent them from having recurrent GI bleeds, but also have a good discussion of the risks and benefits of some of these medications.
I think that's a great closing note, because it's always tough when there's competing risks. And I think it's extra tough when there's competing risks that cross specialties, right?
Oh yeah.
It's like your neurologist, your cardiologist wants you on this, your gastroenterologist wants you not on this.
And he's already signed off and left because it's 3:30 p.m. or something. He ain't coming back. Right?
Yeah. Yeah, exactly. So it's like I think that's something where like a lot more research is needed, and more like, tools to help us decide, because from the perspective of the cardiologist, the AFib is the problem. From the perspective of the gastroenterologist, the GI bleed is the problem. Having objective ways of making decisions like that would be really good.
Yeah.
And as ICU docs, we're always the ones stuck in the middle, having to make that doc on the discharge notes. So
yeah, you're just the ones who are making the ultimate recommendations. So yeah, that already comes down from, once they leave the ICU to the medicine team who's eventually discharging them. So I appreciate it. It's a very difficult situation to be in as well. And also lastly, I want to plug GI Fellowship. I think everyone who's listening should just forget this whole critical care business entirely. Come join us in the ortho, as I've been told, of internal medicine, and it's a great specialty. So everyone should apply and forget all this and just stop listening to this entirely.
I'm sold. I'm ready to transition.
Please come on back. I'll be your program director. That'll be fine.
We're definitely going to edit that part out. All right. Well, that's all we got time for today, folks. We'd like to say a big thanks, first of all, to our guest, Dr. David Dulaney, for helping us provide this wonderful episode. You should check out the show notes for the website at www.criticalcaretime.com. You could subscribe to our mailing list while you're there. You could leave us a comment. We like people who give us shout outs on social media too. We ignore the people who don't say nice things on social media, so don't bother. We always appreciate your suggestions and feedback. So please, thank you very much to our listeners for making it such a fun project to work on.
And while we're on it, thanks to all the folks on our Critical Care Time team who help us with various aspects of the show. Thank you to our outstanding production team at Podpace, App Australia. And of course, a huge thanks to Kurt Belknap, who produced our theme song, which hopefully you're listening to right now. We really hope you enjoyed this show. If so, please be sure to subscribe, give us a like, and definitely leave one of those 5-star ratings that we are always looking for on your favorite podcast app. We sure appreciate that. It helps us tremendously. It helps us expand our audience, and it really does mean the world to us. Finally, of course, like Nick alluded to, those comments are great. We love to hear from you. You can tweet or X at us, whatever it is today, at Crit Care Time. Or you can reach out to us directly. That's at Nick M. Mark or at Askins_Razor. David, I think you have a Twitter as well that you don't really check that often. Is that right?
Yeah, it's still there. So please give me a follow. Maybe I'll, after this, start jumping back on. It's David_D_MD. And I'll shout out awesome. Dr. Blood and Guts as well from Austin GI to look at all of his cool videos. Whether you like GI or not, it's some pretty cool stuff that he's doing.
Sweet. Awesome. Okay. And then, additionally, you can certainly follow us on Instagram, on Threads. We're on Blue Sky. We're on YouTube. We're all over the place. So if you just kind of search Critical Care Time, you'll find us. We just didn't have the foresight to use the same name for all of our social media.
It's actually different on every single platform. Yeah.
Amen. The views expressed within this podcast and the associated media do not necessarily reflect the views of our employers. All references to patients or encounters have been modified to be HIPAA compliant, and thus any similarities to real-world cases are purely coincidental. Finally, this podcast is for educational entertainment purposes only and should not be used in lieu of seeking medical advice. With that, thank you so much for listening. Thanks again, Dr. Dulaney, for your expertise. I am once again, and hopefully always will be, Dr. Cyrus Askin.
And I'm Dr. Nick Mark. Thank you, everybody. See you next time.